Good evening, everyone. I'm Maged Mikael. I would like to welcome you all on the ERC webinar on artificial intelligence in gynecology. I would like to thank you all for attending, and I would like to thank all our eminent speaker, Professor Maged Nabih Kamel, Professor Ahmed Menawi, and Professor Boutros Rizk for helping us to make this webinar happen, and for making a very new, important subject to all of us, practical and very useful to all of us. I would like also to thank you very much, Professor Yasser Abu Talib, for suggesting this webinar and for all his activity and encouraging us all to start the webinar, and for suggesting also the webinar and about artificial intelligence. And I would like to thank all the ERC committee. And of course, I would like to thank IPSA, Dr. Rami Rafi, and Dr. Mina, and Dr. Marcus Hayat for sponsoring this webinar. It gives me a great pleasure to welcome Professor Yasser Abu Talib, the chairman of the International Representative Committee of the ERC-RCOG in Egypt, and the professor in obstetrics and gynecology at Ain Shams University, to give us the welcome note and the opening of our webinar. Professor Yasser Abu Talib.
Okay, that's fine. So, hi all. As usual, we used actually to have regular meeting every 1 to 2 months. It's my great pleasure actually to be in contact, in touch with everyone all over the world, starting from Egypt till India. So welcome aboard. And I discovered that artificial intelligence become a very important subject for everyone. It's now a growing subject and a growing science. So I discovered that it's one of the most important things that we have to discuss this issue. And what's about the relation between this issue and obstetric and gynecology? So it was a great pleasure actually to discover that Professor Menawi from Egypt is interested and he's expert in that. However, I discovered another great expert in the field of artificial intelligence using computer. It's Professor Maged, who is joining us as well. And I would like just to thank very much Professor Boutros from America. He is a pioneer in the field of infertility, and welcome you all aboard. So next slide, please. In view of what we are going to present actually, and I think it will be helpful for everyone to understand the basic principle of the artificial intelligence, I would like to announce 2 or 3 announcements. It's my great pleasure actually to invite you all to our coming international Congress, which will be held on the World Affairs in Egypt during the period between 11 and 12 December. In Egypt. It's a very great 12th conference where the honorary presidential persons will be Professor Dr. Mohammed Abul Ghar, Professor Dr. Gamal Abu Sroor, and Professor Dr. Hassan Salam. So in addition to that, next slide, please. We are inviting all the team of the Royal College back in England. Rani, she is the chair or the head of the Royal College in England. Professor Dr. Hassan Shahata, the vice president. Kate Langster, the CEO of the college. Asma Khalil, the vice president of the college as well. And Professor Dr. Shifa Fatah, who was originally professor of obstetrics and gynecology at Ain Shams University as well. He is responsible for all the training activity, all the activity of the Royal College in a region of the committee in MENA region, and this MENA region includes 6 countries. It's Egypt, Qatar, Saudi Arabia, Jordan, Kuwait, and United Arab Emirates. All of them will be there, in addition to large number of unique persons, many specialty. So I'm welcoming you aboard and looking forward to see all of you as well. Next slide, please. We will have lots of webinar and lots of training programs around. These are our guests from the MENA region. Next slide, please. We will have lots of training programs around gynecology and pelvic floor surgery programs, physiological CTG, as well fetal medicine, where Mr. Hatem and Professor Luke is coming from England to present that, and Professor Asma as well, and it's well known for everyone, as well third degree tear, but as well we will have preparatory courses as well. Especially I'm inviting everyone preparing himself or herself to go through the MRCOG to attend our course, second part MRCOG, which will start 4th of October. I think it will be a very good bonus. Future members and fellow through our special training programs for the second and as well the third part MRCOG. Lastly, I would like just to announce as well that we have website which is produced recently, which is connected to a channel, YouTube channel, where this webinar and all the webinar and all of our activity will be put on the YouTube channel for your revision. So at the end of my presentation, I would like to just thank you all attending our programs, and the coming activity will be January, where we will have 2 webinars, one related to placenta accreta and another one related to endoscopy. One is coming possibly in Dr. Maged Aziz. So
Professor.
Yes, this is our all of our information regarding to our phone number. If you want to reserve anything or if you want to inquire about anything, this is our email and this is the website that we prepared, and you will find as well all our activity through this website, which is connected actually to the YouTube channel. Looking forward to see all of you and have a nice night. Dr. Maged, would you mind to start the presentations, please, and the introduction? Yes.
Thank you very much, Professor. Yes, sir.
Thank you very much.
We are very lucky today to have 3 eminent speakers in the field of artificial intelligence and obstetrics and gynecology. It gives me a great pleasure to introduce our first speaker, Professor Maged Nabih Kamel. Professor Maged Nabih Kamel is very well known for his interest in artificial intelligence, and he will give us an introduction about artificial intelligence. And his lecture is about from artificial intelligence 1 to artificial intelligence 3, and he's going to give us a very brief chronicle of artificial intelligence in medicine and healthcare. Professor Maged Nabih Kamel is a professor and chair of health informatics, digital health since 2014, and he worked in Scotland, the UK, and China, and also University of Lisbon, Portugal. Professor Magid Nabi Kamel, welcome and thank you very much for helping us.
Thank you very much. It's my pleasure to join you this evening or afternoon. And I would like, as Professor Magid had just mentioned, to provide a brief foundation for the rest of this webinar. So I will be introducing, in as much as possible in a non-technical way, a very brief introduction of the various main types of AI in use today in clinical practice. And then I will hand over to my distinguished professors and colleagues to continue providing specific examples from their own practice in gynecology and obstetrics. Let me start by sharing my screen. So that's the title of my presentation, as mentioned by Professor Magid minutes ago. And essentially, I'm going through three distinct types of AI that appeared in this chronological order, but they are not really replacing one another, and they still all coexist today: AI 1.0, 2.0, and 3.0. And I will mention digital twins because they are very important also, and they use various types of AI. Some twins will use 2.0 and 3.0 in the same application or model. And if there is time, I might mention something about AI explainability. But in all cases, I'll be providing with the final thoughts a QR code you can scan to download the whole presentation in PDF format. And then you can access it for self-study and to access those extra bits of information you might have missed or I didn't have enough time to cover this evening. So all will be with you if you just scan this QR code with your smartphone. You will access the PDF, the page where the PDF can be downloaded. As we mentioned, there's three types of AI I'm just going to introduce in a moment. They do not replace one another. They have few other characteristics. We notice that more data and computer power are needed as we go from 1.0 to 3.0. We also note that AI 1.0 and 2.0 tend to have narrow scope and focus. They are sort of task specific. And AI 3.0 applications have broader scope, belong to the so-called movement of artificial general intelligence. They can do many more things and do them without the need to be retrained. They all count as software as a medical device or AI as a medical device, and therefore fall under the established medical device regulation and the need for authorization and approval by the FDA in the United States or at the MHRA in the UK. In case you use them in patient management for specific patient management. But of course, if you use them to just get contextual extra information, which is not customized to a particular patient, or to get the latest guidelines or literature in the context of the particular case at hand, you might be able to escape regulation. But if they are used to generate or help assist in generating the diagnoses or the formulation of the treatment plans of specific patients, then they count as devices and they need to be regulated. And the regulation gets increasingly complex from 1.0 to 3.0. To date, as we speak now, there is no single device belonging to A 3.0, AI 3.0 that has been authorized yet. And actually, the regulation might need to be revisited and go through a complete overhaul in order to accommodate the new types of AI we have today. But most of the 950 approvals by the FDA in America, for example, until September this year, were for AI 2.0 deep learning devices. The first type, AI 1.0, is rule-based. It's very similar to the way in many cases, in many clinical problems, we think in practice by using sort of if-then rules, many of these, and sometimes they are branching. And gradually, as we go through the case, elicit signs and look at symptoms and do further tests and find more results, we can rule out or confirm certain diagnoses. So we start with many questions or things to look at in mind. For example, in case you have got a patient with vaginal discharge. This is a piece of paper I did like 12 years ago about a rule-based system around that topic. Is essentially to demonstrate the engine used to produce rule-based systems rather than to demonstrate a sophisticated clinical problem. So the problem here is just for demonstration. So there are many things you can look at, and you have also many differential diagnoses. If you just start with vaginal discharge, it could be infection, it could be something as serious as cancer cervix or other parts of the reproductive tract. And so we start our journey with a mock chart, how we translate the problem from clinical medicine to something amenable to computer implementation. And then we have a decision table where we have got the different rules. In this case, I needed like 10 rules, 9 rules, and one which excludes all the rest. And I went through, for example, lower abdominal pelvic pain, allergic deodorant use, things related to dyspareunia, or the discharge itself is blood stained or has got a fishy grayish appearance or smell, or frothy, or other manifestations, blisters, sores, and so on. And some of these can coexist. Some of these, to make a diagnosis, you need some of them to be there and others to be excluded, confirmed that they are not there.
Professor Maged, Professor Maged,
yeah.
Excuse me. I think you haven't got the chance to change your presentation to presentation mode. So I think اللي هي علامة الكاس المفروض حضرتك تحطها، عشان كده ما بتلفش. يعني السلايد ثابتة. Just fix it on your yes.
So I stop sharing and please share again. I'm sorry.
Yes, please.
That's because PowerPoint counts as 2 different screens when you maximize after sharing. So what I will go just, this was the slides we went through from the title, and then the agenda, and I mentioned, I think you heard me very well, I don't need to repeat.
Okay.
And this was the general considerations about AI 1.0 to 3.0, and then the molecular chart I just mentioned. And this is the, if you are interested in the paper I was referring to, all the record for it, including the link, the PubMed link to read it, is there at the bottom. And of course, this is just an example of AI 1.0. There are very, very many more examples, and many of them went to history. They are part of our museum now, and there is a historical presentation. I'm providing a link for downloading and reading more about those old systems from the 1960s and 1970s, and they are really the foundation of what we have today. But rule-based systems are still used today, and there are very many modern systems just doing rule-based and probability reasons. Because if you add to rules probabilities, like in many cases in practice, we have probabilities, like something could be 80% this and 20% that, then you start getting the idea of how you combine rules with probabilities. This is a decision table I mentioned, the different parameters and the different rules, trying to confirm different parameters, whether present or not present, in order to reach different diagnoses in our initial differential diagnosis list. So we can, at the end, sort of suggest it's more likely a pelvic inflammatory disease, or a vaginal thrush, or foreign object, or whatever. And we can provide here explanations in the form of canned or text, or baked text that is baked into the program, textbook text, really taken from textbooks that a human can read and understand the basis behind the rule, the reasoning with rules. Then comes 2.0, which is really about the deep learning revolution. Although I'm mentioning it like it came after AI 1.0, but it traces its roots back and is built on foundations dating back to 1943. So we are really standing here on the shoulders of giants. It's not an invention of Google at all. Of course, Google popularized it in the mainstream media and brought it forward by the big investments and by their work on DeepMind and the company they acquired, and the work they have done, including work they have done in medicine. But the foundation was many, many decades before that. And the real reason, really, we just started to see these things during the past 15 years or so, is the increase in the digital data, the vast amounts of data, the big data we have, the imaging modalities now we use in clinical practice. They automatically produce digital outputs. You don't really need even to scan or convert. And we've got also very large increase in computational power. The machines we have today, even your smartphone today, is more powerful than the most powerful computers only 40 years ago, and you just got it in your pocket. And we are still moving forward. Many, many more powerful devices will appear over the coming months and years. So those deep learning systems are task specific. They can only do one thing they have been trained to do, like to read an X-ray and provide a diagnosis for a particular condition or group of conditions that could be found in those X-rays. So they are really very much task specific. To do something different, you have to create a new model and train it again. I will show one example of them, which has been featured in the mainstream news this month in the UK, and has been the subject of lots of coverage and lots of buzz. And let me switch just the sound to the sound of the video is now, and then I will play this video.
We go to the doctor when we have symptoms, but could AI detect problems many years earlier and predict our risk of disease? Well, that's the holy grail of preventative medicine, and AstraZeneca has now unveiled Milton, an AI tool they trained on medical data from 500,000 people who are part of the UK Biobank. It analysed 67 biomarkers routinely collected during health checks, including results from blood and urine tests, blood pressure, respiratory performance, as well as age, sex, and weight. In some of the patients, it also studied 3,000 proteins found in the blood that have essential roles in the body. Milton looked for patterns in the data too subtle to be seen by the human eye. It then used those patterns to identify patients who would go on to develop the diseases up to a decade or more later. Milton was able to predict over 1,000 different diseases with high accuracy, and for 121 it was rated as exceptional. They included dementia, lung diseases like COPD, chronic kidney disease, and some cancers such as those in the bone marrow or the prostate. For a pharmaceutical company like AstraZeneca, it's the blood proteins that are interesting because they could lead to targets for new drugs. But the data is being made freely available to other researchers to develop diagnostic tools. But Milton is so powerful that already some scientists have warned it will need careful regulation to stop it being used by health insurance companies or employers to assess individuals without their knowledge or consent.
At the bottom of this slide, you will find the paper where this research was published just this month in Nature Genetics. And as the presenter here from Sky News just mentioned, you have just seen one of the problems. There are many problems with AI in medicine. One of them is privacy and informed consent and the risks that the patients can have in case this data falls in the wrong hands or is used in a wrong way. Actually, there was a report just this month as well, a very long report, relatively long, and has got those warnings to the NHS that although those results are very promising and some of them are ready for clinical use from a technological perspective, but we are not ready from a regulatory and policy and implementation perspective. We need really to ensure there are no risks presented to the patients in any way before using these things in mainstream practice. The third type of AI is AI 3.0, and maybe many of you heard about one thing about it or heard about something called ChatGPT. This belongs to this class of 3.0. It's not just ChatGPT, and generative AI is not just large language models or ChatGPT. It's much more than that. But that's one popular example we all use. And as you can gather from using ChatGPT, probably by now most of you have used it in a way or other, or so other people using it. It's more general purpose or can do many things like jack of all trades. For example, if you give it some clinical record or clinical findings to summarize and instruct it, please make it as a letter to be read by the patient's mother or next of kin, a lay person. It will do the letter in jargon-free language, very clear for an ordinary person, very readable. And it can still with just changing the prompt, the order or command you give to the model, it can make the same information available in a more professional letter with medical jargon and everything you would expect a specialist consultant to read. They also have multimodal output capabilities, so they can receive as input photos to analyze, to count objects in them, videos for the same purpose, even audio for analysis. This could be even audio of heart sounds or lung sounds or whatever, and fetal sounds, for example, fetal monitoring sounds, and can also give back the other side multimodal outputs in the form of images, text, videos, audios. Some of them, for example, recently introduced by Google, they would take a clinical paper, you give them a research paper you like from PubMed, and it will create a podcast with voice actors. All of them are AI driven, female and males who are not humans. They are AI, but they are very convincing, and they have a very light-hearted discussion back and forth between them about the topic of the paper, summarizing and presenting it. Very interesting. However, these models come with many also challenges and risks. I will just mention briefly two of them. Hallucinations. Sometimes they produce wrong or misleading facts. And the big issue here is that you don't know that these facts are wrong. If you are really unaware or not very careful, or relying just on the AI, you didn't know at all anything about that topic before or about that issue, you might miss something very important in case of incomplete information, or even be misled and get information that doesn't exist, is inaccurate, and also is not there. For example, it can give you a reference to a paper, and it fabricates everything, the author names, the paper title, very convincing, looks really like written by professionals or researchers in your field, for example, and published in whatever journals you read with issue number and years. But when you go to search for it, this paper doesn't exist. The other issue is bias, and bias is really inherited from us humans. When we train AI, we provide incomplete or unrepresentative data sets. So the AI gets those biases, and then later when it is asked to diagnose or to provide recommendations, it still provides biased recommendations because it doesn't know better than that. It just used our data and our limitations. So it's just reflecting our biases, whether they are human, societal, or clinical. Doctors are already using it. ChatGPT is one of them because it's available to everyone, including the version of it with Microsoft Bing, the search engine by Microsoft. And in the UK, it's said that British family doctors or GPs, general practitioners, are already using it extensively. 1 in 5 of them are using it to suggest treatments, to help diagnose conditions, or even find treatment options they don't know about, and to write letters, referral letters, and so on. Of course, this is not the correct way of using AI, and ChatGPT is not meant for that particular use. Even in its terms and conditions by OpenAI, it completely forbids the use of ChatGPT in all of its versions and successive releases in anything that is related to medical advice or treatment of specific individual patients. It's also the liability falls always on the GP or doctor. You can never blame AI or the company producing the AI. It is your responsibility, and you are the human in the loop in charge of all of this. Anything goes wrong, it's the physician to blame, really. So what do we do in medicine to improve upon the general purpose models like ChatGPT or Gemini from Google or Meta, Facebook are having their own also go at this with the series of Llama models they have produced and many others. What we try to do in medicine is to provide specific purpose models. Although I call them narrow focus, they are really much more than narrow focus. They are like a student you send to medical school to study medicine versus someone who is well educated, but perhaps in other fields or in general knowledge, but never had the chance to study in a school of medicine for a dedicated number of years with dedicated resources and meeting experts in the field in order to get to learn the profession from them. So these models were trained like medical student trained at medical school. We have of them a few, and the numbers are increasing, and many versions are being produced that are getting better and better, like MedPalm and Meditron and MedGemini and Clinical Camel. And sometimes they are combined. More than one of them are combined in a single application to sort of help one another. But we even went further than that and started, instead of training a model in LLM, a foundation model or large language model in all of medicine, we focus on certain specialties, like on a pathology foundation model for cancer diagnosis and prognosis prediction, or a radiology specific model. Harrison Rad 1, just released also this month of September, is really a very novel medical specialty specific model. I've just got a very small, very short I just discovered that you probably didn't hear me all the past slides. I was just mentioning the different models, whether they are general purpose or medical specialty specific models, or now the example about radiology I'm about to present. I also mentioned hallucinations and bias as main issues we encounter with AI 3.0. I also mentioned that they are multimodal. They can be fed, or they can ingest all sorts of inputs, text, audio, video, and can return also the same. You can enter a text prompt and receive an image or a video or an audio. You can send them, give the model, for example, an image, a medical image, and ask the model to analyze and write a clinical report about that image, and so on. I will just provide now this video of one of the specialty-specific models that is one of the most accurate ones. It's just released this September, and you can see the difference.
Harrison-RAT1 is a multimodal foundational model that is focusing on the field of radiology. Unlike other LLM systems that has been trained on the public internet, Harrison-RAT1 has been trained specifically on high-quality medical imaging data. Harrison-RAT1 is capable of analyzing medical images like X-ray and plain film of any body part, and is able to use natural language to answer questions such as detecting and localizing findings, categorizing them, describing changes over time, as well as give recommendations to clinicians using it. Harrison-RAT1 is performing extremely well, even on challenging examination designed for human radiologists.
So let me... I just returned the mic. Apology for that, because I need always to switch between the microphone and the screen. And let me share the screen again, the window. And that's the PowerPoint again. So to reduce hallucinations, which is one of the main problems with these models, we try really to sort of give the model additional help. Like you have an LLM, a large language model, and you ask it questions, but you don't just rely on it to make the conversation with you and to just generate whatever answers it might think are correct to produce, but you are also providing it with a textbook or a source of information and telling it, please limit yourself to that particular body of knowledge I'm giving you, a range of, for example, textbooks in your specialty, or a body of literature made of research papers you have retrieved by PubMed on a particular subject. And this sort of augmentation, called the retrieval augmented generation, can help you in many ways. You can then lead a conversation with the LLM as if they are experts, the authors of those material, asked for summaries, for cross-linking of information, synthesizing topics that span multiple chapters or papers, produce the beginnings of a systematic review, for example. Even self-test yourself by asking the model to ask you questions, MCQs, and correct you. Then you know that it gives you the answers, and you can know whether you have answered correctly or not. You can do many things, and the best thing is many of these models run on today's high-end computers. Most of us would know them because our children are using them for gaming at home, or for playing, and we think these are just expensive toys we have to buy for our kids, but they have also a very serious use. If you manage to borrow it, if you can, for some time from your child, you can install these things. And the example I provided was a piece of research we did in dermatology with NVIDIA Chat with RTX, that just published this July. But of course, you can remove dermatology here and put whatever specialty, gynecology, obstetrics, or any other specialty, and the same technology will work fine. The digital twins, which is the last thing I'm covering today in the types of AI, are essentially having a model that represents the whole body, which is quite rare, and we don't have these models so far. This is really our utopia, or our vision for precision medicine in 2050. But we do have models that would model certain things like pregnancy, like a certain organ, a body organ, the liver in a particular patient, or a body system. We can have many of these models. One for each one is representing a unique individual. And when you combine them, it's like you got an aggregate, a population model of the liver, for example, of Egyptian population. Of course, you would not be able to do it for 100 million Egyptian, but maybe you can get the data for a representative good number of people, and you have a model for each one, which is unique. And then you can start studying things in a population. This was a paradigm first introduced in the manufacturing industry like 20 years ago, and then used by NASA for simulating their spacecrafts. And then later it was brought to medicine, and we are using it right now. The idea is with those models, you can do something called in silico testing. Suppose you have got a patient. We all know that patients do not all respond equally to the same treatment. And sometimes there are many options for treating the same condition or the same sort of patient profile we have. But we are not really sure which one really will work best for that particular person, given their unique characteristics, which in many cases, sometimes we don't know all about those unique characteristics. Everybody is different. Even when they are two identical twins, there are still some differences because of the environment and what they have been exposed to and so on, and epigenetics and so on. So we imagine I give you a tool whereby I can have 3 copies of the lady you are treating, and those 3 copies can receive the different treatments or interventions, could be surgical procedures or whatever. And I can give you, I go through everything. I show you the response of the person and the outcomes at the end, how the disease responded or the condition or whatever you are intervening to do, how the response was. And then you can see which one worked best for that person, and then try to use it with your real patient. And you can still monitor that patient and feedback to the model to improve it. And so on. The loop is closed and continues. We do have this today. It has been, for example, applied in atrial fibrillation and so on, in many other diseases where you have multiple modalities and options for treatment, and different persons respond differently. And it's being used and increasingly important in medicine. The type of AI these models use is usually 2.0 and 3.0. Sometimes we use them to reduce the time for clinical trials, to generate the control arm or most of the control arm. So you get synthetic humans serving as control group in the clinical trial. This method is approved by the European Medicines Agency. It's based on digital twins, and it uses generative AI. It uses 3.0, and it's quite promising. And it just shows you one use that is helping us have significant cost savings and having also shorter times without sacrificing quality. You are still doing good trials. Explainability, I better leave this topic with all the philosophy in it to those of you who are going to download those slides. I've just produced now the QR code for the slides, but you probably learned about the latest OpenAI O1, which is the latest form of ChatGPT, not fully publicly released, only a cut down preview of it has been released, but it's really capable of doing magic things. And the best thing is it has got a chain of thought option where it will tell you why it is telling you this final conclusion or recommendation or diagnosis. And it's really producing things like the level or the standard you would expect. For example, when you have an MD candidate, a mature postgrad who is examining, going through the exam of their MD during the oral, and you ask them a question or give them a case to diagnose, and they give you the correct diagnosis, then you follow with another question: how or why did you reach this diagnosis, and how did you exclude other things? What did you exclude in the process? And then they give you that comprehensive answer you would expect from a successful MD. This is exactly what we have today, with all, of course, the limitations we mentioned, which still need to be ironed out and need lots of work to further improve the technology and make it ready for use in practice. Explainability as such also is an issue of
Professor Maged.
My last slide.
Yeah.
I'm mentioning.
Yes. Okay. Thank you.
You can have AI without explainability, and it can be very useful. And lots of the AI approved by the FDA for mainstream use doesn't explain why it reaches recommendations, yet it is very safe and effective and can be used with real patients. That's the final conclusion, is that AI now, even in surgery, using transformer architecture, which is used in ChatGPT, is learning from surgeons' procedures and then mimicking them. This transformer ChatGPT-like sort of architecture is used here to teach the Da Vinci robot how to do stitches by just observing a human surgeon at the beginning, and then the robot imitates what it has seen. So undoubtedly, this is a disruptive technology for the whole medical profession in the coming years, and we need to rethink our education and curriculum. And that's the QR code and the last slide. So please, if you want a copy of this slide, just scan this one. You can download the PDF and access all the material. Thank you very much. And apology for being long and the technological hiccup of the sound in the middle.
Thank you very much, Professor Maged. A great lecture as always. We have the two quick questions, please, to keep the time. The first question is about the future of medical publication in Obs and Gynae, especially for those who have language barrier.
Yes, you can. Currently, all journals have AI, use of generative AI policies. I'm the editor-in-chief of a journal with Springer Nature, and we do have this implemented. We first implemented it in our journal, and then we got the general policy implemented by our publisher, and they rolled out this policy across the whole portfolio of Springer Nature. Elsevier has got a similar policy, and so on for other publishers. And they usually, during submission, you will have a declaration that you need to confirm if you have used any form of generative AI in the preparation of your paper. You have to declare it exactly how you have used the AI, for what purpose, and which model or type of AI you have used. If it is just to improve your language, the language of your work, that's fine, and you can use it, and you should declare it that you have used it. And it is at the end your responsibility and your paper. The AI cannot be the author of any paper. But you cannot really use AI to generate the research itself, although it can produce things that are very convincing and can even fabricate data, but all of this is unethical. If you have used it really to generate or to help you generate methodologies or plan, this might be approved in some forms of these are not really publication. In some protocols, some grant awarding bodies accept this form of use of generative AI to prepare research protocols. And AI, like O1, for example, is currently being used to produce, even generate novel ideas. But at the end, it's you, the scientist, who should review all the output, and it's your responsibility to ensure its plausibility, its validity, and to sign it off, and it will bear your name, and you are the one responsible. You are the guarantor for that output. So yes, please go ahead and use it. It's allowed to be used, but you have to declare it.
Thank you very, very much, Professor Maged. That's been a great lecture. Thank you very, very much.
Thank you.
Our second speaker, we are very lucky to have Professor Ahmed Minawi. Professor Ahmed Minawi is very known to all of us in the field of Obs and Gynae, and he's a professor of obstetrics and gynecology in Qasr Al Aini School of Medicine. He's a former adjunct assistant professor at the University of Rochester. He's a founder of the Virtual Endoscopic Simulation and Skills Acquisition Lab at Qasr Al Aini, and he's a founder of the Obstetrics Extended Reality Lab at Qasr Al Aini. He's going to give us an important lecture about artificial intelligence and its current and potential uses in Obs and Gynae. Professor Ahmed Minawi, thank you very much for your time.
Thank you very much. The pleasure is all mine. I would like to thank Professor Maged Boulos for truly an excellent presentation. Very, 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 very thorough. And I did take the QR code to read up on this. As we were talking, I was going through my slides and I changed some things to make it far less technical. And because of the time constraints, I've removed a lot of things, so I'm just going to sort of like skim over the potential uses. I'm not going to go into the details of the types of algorithms that are in use. Let me just try and open up the presentation 1 second, please. Okay, so next step. Share presentation. Is this now, can you see it now?
Yes.
Can you see my presentation?
Yes, we
Hello?
can.
Yes,
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 we
we
can.
can see.
Okay,
Yes.
that's great.
Okay,
Okay.
thank you very much.
Thank you.
Okay, so as I said, I'm going to skim over a lot of the different potential uses for AI within the time constraints. I'm trying to rush as quick as I can. First of all, artificial intelligence actually stems from our natural biological intelligence. So in other words, everything AI is actually from us. It starts from our brain. And ever since the millennia, the human brain has evolved from developing using stones as tools to the extent that we now mind control a variety of objects, actually. And because of this, the human brain can only process only limited data. So this means that we have information overload. So we're actually drowning in a sea of data. And because of this, we need actually AI to build ourselves a lifeboat for data management. Back in World War II, Alan Turing, who devised the first computer, said, I propose to consider the question, can machines think? And this leads us to the importance of artificial intelligence in healthcare and in obstetrics and gynecology. So basically, artificial intelligence, very simply in a nutshell, it's focusing on the use of computer algorithms to understand and simulate intelligent behavior comparable to what we do. And to put it really simply, we have data. And this data, I apply an algorithm to it, and it performs a task on behalf of me or in assistance to a human being. This is simply what AI does for us. As Professor Magid was saying, there is a lot going on, but everything is under the umbrella of machine learning. So I'm not going to go into this, nor am I going to go into generative AI, which basically is the future because it focuses on creating new content. And this is our doorway to self-recognition later on and autonomous robots and autonomous AI later, maybe a decade or so down the road, or maybe even quicker. You never know. Now, as Professor Bolos was saying, the USA Food Administration updated in August, actually, 950 AI-enabled devices, which they licensed starting 1995 till 2024. And as you can see here, the graph, there's a huge increase since 1995 when they had one piece of equipment licensed and up to 108 last year, and this year about 135. Sadly, if we look at the number of devices by medical specialty, we'll notice that obstetrics and gynecology is way down on the totem pole. We only have 5 devices. Whereas if you look at radiology, 76% of the 950 devices are related to radiology. The rest are cardiovascular, neurology, etc. So we have a lot to do when it comes to obstetrics and gynecology and artificial intelligence. And here is a list of some of the things that we can talk about in obstetrics and gynecology, but I'll go through some of them quite quickly. The beginning is computer vision, which uses deep learning-based image interpretation. So let's start with something that we see on a daily basis as obstetricians, pap smears. So we have AI deep learning computer vision for pap smears. And this study from Norway in 2017 got 4 expert pathologists, gave them 100 pap smears, asked them to give us a diagnosis. Believe it or not, the best case scenario was only moderate agreement, which is really not very good. But at the same time, look at the study from 2024 by Tan et al. And they took a multitude of image sets and they used deep convoluted neural network learning algorithms, which are the best for this sort of classification. And they compared 13 different convolutional neural networks. And the core message in the end was that these CNN models significantly enhance the accuracy and efficiency of cervical cancer detection from pap smear images, better than humans sometimes, potentially reduce the workload on cytopathologists and minimizing human errors in diagnosis. So quite important. But what about direct colposcopic visualization? Can I take the video output from a colposcope and ask AI to help? Yes, all the data starting to 2021 says so. Look at this paper from 2023. This is a handheld colposcopic AI device, and basically it utilizes convolutional neural networks. It takes the cervical images and then it analyzes them, classifies them, and comes out with the areas that it detects as cancer. And it does so with extreme precision, to the extent that the accuracy was 96%, which is actually astounding. Now, if you go further, let's talk about HPV. This is why we do pap smears in the first place. It causes cervical cancer, which is preventable. So early diagnosis is key. Can I actually see HPV? Can I? Well, according to this paper, yes. Takahashi back in Japan in 2024 just published this using the device on the right-hand side, which is also another handheld colposcope, and it focused on using AI to detect high-risk subgroups of HPV. So basically, what they found that they could train it to associate specific colposcopic image features with high-risk HPV infection. And in the end, they found that the accuracy, sensitivity, and specificity of this AI-assisted colposcopy system in detecting high-risk HPVs was actually quite respectable. Now, also, we have real-time surgical assistance. Now, what do we mean by real-time surgical assistance? I have augmented reality. So augmented reality means that I take my view of the real world and integrate it so I can literally interact with that. So how do I do that? I use special devices, HoloLens or the Apple Pro Vision, which are augmented reality glasses. So what about in the operating room? Say I have a surgeon undergoing surgery and I need to see x-rays, MRIs, etc. I'm not going to waste time moving around, looking from here to there. If I could be just in front of me, that would be a lot easier. And so actually started doing this in Cairo 2 years ago. Here I am doing laparoscopic myomectomy, and I'm wearing the HoloLens, and here, literally floating in midair, are color augmented MRIs of the patient showing the locations of the various fibroids so that I do not miss any of these fibroids. Now, I can also use AI in preoperative planning to visualize structures. So I can do a 3D CT or MRI of the patient and then generate a 3D model. And I can use that to perform virtual surgery beforehand. So this allows for personalized planning and simulation of the surgical strategy. Now, here, this paper out of France last year was doing the same for deep infiltrating pelvic endometriosis. And they were actually extracting the data from the MRIs and producing 3D models, which allowed surgical techniques to be pre-planned, proper instruments to be prepared, and potential difficulties to be avoided. And here in Cairo, we're not sleeping. We're actually collaborating with Japanese researchers to implement this in cases of frozen pelvis so that we know what we're going into. Which brings me to the next step, which is interactive medical imaging. Now, dynamic overlay of the preoperative anatomical knowledge that I got through the 3D MRIs or CTs, I can put that on top of robotic or laparoscopic operative field. So this allows me to make critical real-time operative decisions and stay away from potential danger zones. Here, for example, the study in France, they were doing the same for the ureter. And so here they're superimposing the ureter onto the image during surgery. Here, liver masses. Now, liver masses, what has this to do with Ob Gyn? It's just that the algorithms they use can actually be used by us gynecologists. So here, for example, we have a picture of augmented reality of the actual masses within the liver. And here is a robotic surgery. Here are the instruments. This is the live picture. And on the left, on the bottom, you can see the augmented reality view. So the surgeon knows where exactly to do his incision. And here, this was a study that was done 2 years ago on pigs, and it was targeted lymph nodes. And here you can see that they've superimposed the blood vessels and the lymph nodes so that they can either do the dissection during surgery safely. Now, augmented reality in surgery has been around for a few years, and the people who've been using it the most have been the neurosurgeons. But we gynecologists have not been sleeping either. Nicolas Bourdelle in France has been trying for several years to do this, and he's been doing basically MRIs and then superimposing after doing fusion phase onto the actual uterus live, either laparoscopic or open surgery. And this is what he does. And so we can go in and do open surgery or laparoscopy without missing anything. And he's actually now profiting on this by starting up a company. And what we also do is surgery for simulation training. And this is where AI is also important, because with simulation, I have the ability to fail multiple times and allows proficiency-based training. So in other words, practice makes perfect. And using extended reality, which includes virtual reality, augmented reality, and mixed reality, we can do all of that. And the American College of Surgeons, June 2024, said that AI can enhance surgical education and training, and all studies have shown that simulation-based training produces skill sets 40 to 70% better than regular training. And what's important to know that memories are longer lasting when they're significant or repetitive. And this is where VR training helps, because we can repeat once, twice, 100 times. This is an example of virtual reality laparoscopic simulator, which has haptic force feedback. In other words, I can actually feel, so it's not a video game anymore. And haptic feedback is a very important part of training. And it also allows 2D, 3D, and immersive 3D and multiple surgical scenarios. So like, for example, hysterectomies, for example, very lifelike. This we have at our virtual reality lab in Australia. And then we also have immersive 3D in the same device, which using special glasses allows the doctor to be within an operating theater. I can add nurses, etc. So this is good for novice surgeons who just are starting to know what it feels like to be in an OR. And then we have even higher levels of AI. This is the most up-to-date surgical simulator we have for laparoscopy. It also has ergonomics. And this allows us to, here you can see several of our doctors working on it. And it allows us to have a cameraman, an assistant, etc. And here, this is a study that we were doing. And here we're teaching them ovarian cystectomy on this. Now, if you look up on the right, this is what it looks like from the simulator. Now, look below. This is what it actually looks like in real life. It is almost exactly the same. And the doctor on the left is one of the PhD or master's students actually that was training on this device. And then we have the high fidelity birthing simulators, which allow augmented reality to train on conditions that are not always seen, such as shoulder dystocia. And then in surgical practice, of course, robotic surgery takes the prize, because how do we define AI in surgical practice? It's either assisted intelligence, augmented intelligence, or autonomous intelligence. We don't have autonomy yet. All we have is level 2, which is task autonomy, meaning I tell the robot what to do and I control the robot. This is what a normal robot looks like. It's huge, but AI and neurotechnology have allowed us to have miniaturized robots, which are now only starting to become online within the next year or so, and promise major changes in the way we do surgery. As you can see, lots of papers out on artificial intelligence and use in robotic surgery. One of the most important is haptic feedback, because laparoscopy is all about haptic feedback, because I can actually feel. But robots have not had that capacity until very recently. The Da Vinci, when it came out in 1999, did not have any of this until this year, when they came out with the Da Vinci 5 that has haptic feedback and that allows the surgeon to actually feel what he or she is touching. And this is a major contribution. Now, artificial intelligence sensor technology that allowed that have been around for a couple of years in the Sen hands, but it never took off because Da Vinci is a far, far, far better algorithm. So artificial intelligence algorithms spell the difference between success and failure of a business model. And you cannot copy an algorithm like you can copy an application. So the benefits of incorporating AI into robotic surgery, data analytics, digitizing surgery, surgical workflow, analyzing surgery, all this helps avoid obstacles during surgery and warns the surgeon of potential complications. The future is going to be cognitive robotics. It'll do things by itself, analyzing surgical skills and actually assisting. Which brings us to endometriosis and artificial intelligence. Now, all of us know how bad endometriosis is. 10% of women are affected. It takes 8 to 12 years until a proper diagnosis can be done. So can AI help? Well, there are studies going on, and this was the latest in 2024, and it shows that biomarkers are being developed using AI, proteins, microRNA, and also using AI, transvaginal ultrasound, and MRI. So we're going to fly off to Australia, where they've been trying to do this. And 2 universities actually collaborated on this, and they used a combination of MRI and ultrasound to detect unpaired endometriosis, basically deep-seated endometriosis using this technique, which is very good. But the drawback is that they're using very expensive MRIs in addition to ultrasound. We don't have MRIs in our offices. So a more simple office-based algorithm is probably going to be more practical, which allows us to fly off to the other side of the world, to Switzerland, who are also very practical people. And at ETH Zurich, they started using transvaginal ultrasound and an algorithm. And they're headed by Stefan Tuschmid, who is the head of the AI center in ETH Zurich. And basically, they've used labeled expert data, more than 2,000 videos and counting. And what they're doing is real-time classification using convolutional neural networks. And using this, they allow us to actually see the areas of importance and at the same time give augmented reality views and 3D views to show you where exactly you're pointing at. And so far, the data has been very, very, very good. Now, brings us to AI in obstetrics. So all of us obstetricians have been using AI for quite a long time if we have good equipment, because it allows for automated recognition, anatomical measurements in most of our higher end ultrasounds. We automatically press biparietal diameter, it'll choose it for us, femur length, etc. But not everyone can afford an expensive, artificial, intelligent enabled machine. Not everyone is a good sonographer. And this is what made Jeff Stringer from the University of North Carolina a few years ago start something called the FAMILY Study, Fetal Age and Machine Learning Initiative Study between the United States and Zambia. And what they wanted to do was to provide an artificial intelligence module that could be added to any cheap ultrasound and used by any novice ultrasonographer. And so here, what they're doing is very simply, they're measuring the abdominal girth, and the measurement is entered in the tablet, and then this allows them to tell us how many sweeps to do. Very simply, we just sweep left to right, top to bottom, very, very easily. And then they press the button, and the result is available instantaneously. And they published this just in August of 2024, and they enrolled 400 pregnant individuals in this study. So what did they say in the end? They said that novice clinicians using this device estimated the gestational age as accurately as a credentialed ultrasonographer. And they found that the difference between an expert and a novice using this machine was a difference of only 0.2 days in gestational age. So this is really awesome. And then this is another proof of concept that's actually they're working on. They started in 2022 using deep learning in fetal ultrasound analysis for diagnosis of cystic hygroma in the first trimester. And here, as you can see, the red area is the area where it predicts where the problem. And they used a data set that had almost 289 images. The sensitivity was almost 92%, specificity almost 94%, which again is really, really impressive. And then we have advances in the application of artificial intelligence, fetal echocardiography. And here they take multiple image sets and classify them. And then in the end, using convolutional neural networks, come out with diagnosis. So this allows enhanced detection diagnosis, automated image analysis, and real-time monitoring integration with the clinical workflows, something that we're all going to be using within the next decade. Same goes for electronic fetal monitoring, because the main objective is the early detection of life-threatening fetal hypoxia. So it allows enhanced accuracy, noise reduction, and more important, predictive analysis. It can tell you when to intervene if there's something going on that is bad for the mother or bad for the baby. And then finally, AI in ovarian cancer early diagnosis. Of course, cancer is a disaster. We all know A125, but here they're using transformer-based AI algorithm technology to using cell-free DNA methylation markers. And this was a really important study that achieved 80% sensitivity and 90% specificity in early stage epithelial ovarian cancer based on this methyl-BERT algorithm model, which they trained on 110,000 cases. So this is truly going to be a game changer if this algorithm is as good as the publication says. And so in the end, I'd like to say that healthcare future innovations will come from how we use the data to find new breakthroughs in patient care. And I'm sorry if I took too much of your time. Thank you for listening.
Thank you very, very much, Prof, for an outstanding presentation and truly an eye-opener and stimulating for all of us to know more about artificial intelligence and to keep updated all the time. We have two important questions, if I may. The first question is about the acceptability of the public for them to know that doctors depend on artificial intelligence in their treatment. What are your thoughts about that?
Professor Ahmed is there?
Yes, I'm there.
Yes. Magid, would you mind to read the question again?
Yes, of course, yes. Thank you very much, Professor, for an outstanding lecture. We have two questions. The first one is about the acceptability of the public to accept that their treatment will be involved with artificial intelligence. What are your thoughts about that?
Well, in the end, as I said in the beginning, artificial intelligence is us. I mean, any data that they get through generative AI in the end is scientific information. But as Professor Magid was saying, I can feed the algorithm baloney and it'll spew out baloney. So of course, if you're not using the proper type of algorithms to look up whatever it is you want to look up, then of course you run the risk of giving false data. Another thing is basically we're talking about ethics here. So, I mean, in the end, we are doctors. So we have studied for years and we continue studying throughout our lifetime. So new information comes out on a daily basis. So I think it would be unfair to say that patients are angry that doctors are using generative AI, for example, to look up whatever is new, because in the end, every single day we have new information. So I really think that patients need to be made more aware of what exactly artificial intelligence is providing to the doctors before saying that, no, this is not correct.
Dr. Ahmed, if you allow me, Magid, if you allow me just question, Ahmed, it's unbelievable what you have done. You have been playing with our mind over the last 20 minutes. It's great, great, great. I'm impressed with what you have done. And I discovered that artificial intelligence is completely different from what we got in our mind, actually, because I'm a little bit confused now. Despite the fact that I'm afraid of artificial intelligence to limit the activity of a doctor and his clinical issue and his clinical capability. But I discovered that the artificial intelligence, what you said, actually, it's there to support us to locate the place of the disease, and that's it. So it means that I am going to diagnose first and do my work as a clinician and take other machines to support me in management. But what's what Professor Magid said regarding to type 3 artificial intelligence? I think it's different because I'm confused now between application for the machine. Yes, regarding to hallucination, bias, and fabrication. So we used actually to feed the machines with lots of information. But how can we guarantee 100%? There is no hallucination, bias, and fabrication. So do we have certain criteria to feed the machines with that? And do we have difference between what's called artificial intelligence? Because I feel that type 3 is nothing except just data collection. And for example, if I wanted to prepare a lecture for the students, and that's it. And Professor Magid warning against false information regarding that. I think it's different from the machine. How can we contribute? Do you think there's difference between both of them?
Well, the type 3 or generative AI, these use something called large language models. And there are things called multimodal large language models, like he was explaining with the Harrison AI. And this is something called open-ended. Open-ended means that these algorithms are not specific for that specific application. In other words, it can learn. And so this generative AI, to the extent that, yes, it can produce false information, but also it has regenerative capabilities, so it can actually learn from its mistakes. And so I think that as we go along, the algorithms will change to the extent that we can, in the end, stamp out these hallucinations, as Professor Magid called them, because in the end, we are baby footsteps. I mean, this is right now, we are exactly where we were when the World Wide Web came out back in the early 90s. People didn't know what to do with it. And nowadays, you don't have to be a computer programmer to put together an algorithm. There are now algorithms that help you make algorithms. And so I think that within 5 to 6 years, you'll be seeing a lot of the younger generation playing around with algorithms just like they do with applications right now. I mean, if you go onto any of the app stores, you'll find thousands and thousands of applications that have been done by teenagers. So the same thing will go with artificial intelligence. And this is where ethics comes into place and regulations come into place. And the United Nations is now taking measures, and many countries are now taking measures to control artificial intelligence, because right now where it stands, it's bigger than any of us. But in the end, we are the ones who are feeding this information, and we are the ones who are producing the algorithms, and we are the ones who are able, with the help of the algorithms that we produced, to fix the faults that we will find now or find in the future.
But do you think that we might have a time where everyone carrying in his pocket his telephone, even the patient himself, and feed the telephone and said that I have a fever and I have pain in this place and I have pain in my arm, and so what's the diagnosis and what about the treatment? So we can tell the doctor. Do you think we will reach to this stage?
No, you'll never cancel the doctor. What it will do is it will actually make life easier for the doctor, because in the end, the patient is going to come in and he's already researched a lot, and he's going to give you a lot of this research. So it's just going to make your job easier, because in the end, we are the filter. We are the people, we are the convolutional neural network, so to speak, because I mean, artificial intelligence in the end was modeled after our brains. So no, I think it's not going to negate doctors at all. It's just like basically cars. Did they negate drivers? No, even self-driving cars, you still need drivers. So in the end, we will still need physicians, because we are the ones who study, we are the ones who have the clinical sense, and AI in the end is all about data. But the clinical sense, the intuition, which is what we have as human beings in our brains, is not there. Whether or not they will get this in the future, only God knows.
Thank you very much. It's wonderful. Thank you very much. Magid?
Professor, I think your lecture inspired everyone, and we have more questions, if we may. The second
I can't hear you.
About medical knowledge to everyone is something you agree with or you disagree?
I don't understand the question. Say again.
The question is about the availability as well of the medical knowledge to the public. Are you with this or you are against it?
No, I'm with it, because knowledge is knowledge. You cannot. You can go and buy an encyclopedia and read all up about everything. So yes, knowledge is free. Knowledge is for the people, and if we did not have knowledge, we would not have any of these devices. Because in the end, most of what is being made for us doctors is being made by laymen who are not doctors whatsoever. They're computational experts using mathematical algorithms to help us help other people. So if you come and say, no, I will not allow people to have access to this info, you're doing humanity a very great injustice.
The second question is from Dr. Muhammad Wala El-Zib. He wants to thank you for your amazing and outstanding presentation. And his question is about the cost of RI to be applied in many universities like yours in Qasr Al-Aini, and whether this could be applied, and he hopes to see it in Alexandria very soon.
Well, in the end, I mean, when we're talking about AI, as I said, we talk about a variety of things. So I guess he's talking about AI in surgery. So in AI in surgery, if he's talking about augmented reality, then he's talking about the augmented reality glasses, which cost on the average of around $3,500 to $5,000 each, which is not relatively expensive. What is expensive is the software and the algorithms that run them. Those are the very expensive things. And like one little example is that, for example, if you want to have an anatomy program running on a HoloLens, which allows you to go through the body piece by piece, area by area, that is a license, not something that you can buy outright. And it's around $3,000 to $4,000 per year per device. So yes, these are expensive things. And if we're talking about the augmented reality devices or the virtual reality devices, so each of the devices that were shown on screen costs on the average about $150,000 to $160,000 US. So these are, yes, very, very expensive pieces of equipment. And I would like to say that all of the equipment that we were able to get at Vizalca was not paid for by the government nor by the university. It was all by donations through private individuals. So I would highly recommend that if anyone is interested in doing something like we were able to do it through people who donate because they have an interest in education. Because currently our universities just do not have the amount of money needed to start up things like we started.
So
another question.
Maged, yes?
Yes.
Professor Boutros is there or not yet?
He's logging in.
He's logging in, that's fine. So may I add a question, if you don't mind, Professor Ahmed? Do you know we have a robotic surgery in Shams University in one of the greatest hospital there, and it's applied for maybe 2 years now. But the point is, the cost of ovarian cystectomy in one of our patients, nearly it's 50 to 100 grand. Just simple cystectomy, just an ovarian cyst of 5 centimeters, and that's it. So this is the actual cost, which is very expensive in comparison with the normal or the usual practice in laparoscopic surgery, which might cost maybe 5 to 10,000, 20,000, and that's it. So what's the value of using this very expensive machine in the time paying in comparison with the classical one? Do you think it's wise? So what's the value? Are you urging us to use that extensive or very expensive machines instead of the classical one or not? What's the advantage over other machines?
Okay, when I started robotics back in 2013, we're using the Da Vinci. And the Da Vinci is truly the Rolls-Royce of robots. And currently, the Da Vinci is 10 years ahead of the CMR that you have at Ain Shams University. The thing is this, robotics is not for everything. For simple hysterectomies, for simple cystectomies, it truly is a waste of money and effort to do that. The thing is that in a lot of hospitals in the United States, for example, okay, these machines are amortized over years and you have multiple people using them from a variety of branches. And so the cost goes down. But here, the cost per case is quite expensive. And knowing the fact that we have a very, very bad exchange rate with the US dollar now, it means that it is truly impractical to use the robot for simple hysterectomies. It's good for oncology. It's good for colorectal surgery. It's good, of course, for prostatectomy, where it is the gold standard. But for simple cystectomies or simple myomectomies, I would say it's overkill and definitely not worth the money.
That's great. Thank you very much. Thank you very much. It's wonderful, to be honest. Magid, I think Professor Boutros, hi, Professor Boutros. Well, everyone here in Egypt missing you very much. How are you doing? Hope you are well. Okay, so pleasure actually. Magid is going to introduce, but everyone say hello to you.
Thank you very much, Professor Menawi, for a great lecture. It has been inspiring indeed. Thank you very, very, very much. It gives me a great pleasure to introduce Professor Boutros Rizk. Professor Boutros Rizk lectures and knowledge inspires everyone. And thank you very much, Professor, for agreeing to give us a lecture about artificial intelligence and ovarian stimulation. Professor Boutros Rizk is very well known, but I would like to introduce him as well. He's a professor of obstetrics and gynecology, the head of reproductive endocrinology and fertility, medical and scientific director of in vitro fertilization and assisted reproduction at the University of South Alabama. He's the lab director to Odessa Fertility Lab at Odessa Regional Medical Center and faculty member at Texas Tech University in Odessa, Texas. Professor, thank you very much for giving us this lecture among your busy schedule. Thank you very much. Professor Boutros, I think you need to unmute yes.
Unmute.
I think, Professor, you need to press on the mic. Yes,
thank you so much. It's an honor. It's my pleasure. There is no other group of people that I would like to be associated with and enjoy the company, more than this group of eminent physicians. Dr. Magid, my pleasure. Dr. Yasser Abu Talib is my honor. And Dr. Ahmed al-Menawi, I heard half your lecture and I'm dying to hear the other half, but I'm always excited about your innovation and your constant foot on the pedal, as we say. I heard you ending with the robotic. Let me tell you that the last 15 years of my career, although has been always mainly IVF, but the robotic has been the most enjoyable part. Partly when you get older, you also like to sit and and it takes the shakiness from my hand. For you have none of these issues and so on. But I honestly do 100% of all my cases robotic. There is 0% of anything else. But your points are very, very well taken about finances and volume of cases and number of subspecialties. In the beginning, the US, they loved that urologists do it. So we could never even schedule a patient in the OR because the urologist, then they changed the urology management of prostate cancer. So suddenly we became popular again. But one time we'll join you on that realm as well. It's my great enjoyment here to talk about artificial intelligence. I have to say that my personal experience has been very short and very limited. We're doing this year annual ASRM, the American Fertility Society, American Society for Reproductive Medicine, whole symposium on artificial intelligence. To show you how little I know, all the people that I invited were people outside of my team completely. So we brought people from Eastern Europe mainly, and then from some of the centers in the US that has already implemented artificial intelligence. Basically, 2 points very quickly that I would like to make. There is the clinical part and there is the lab part. You can implement artificial intelligence in the 2 parts. As far as the lab part, you can employ it in 3 areas: in the embryology part, in the andrology part, and then in the technical, where you match patients that you got the right donors, the right recipients. I don't mean like a third party, but even like within the couples. From the clinical part, so far it has focused on a few things. So far it has focused on the stimulation and on ultrasound. So ultrasound, there is all those big companies that have access to this kind of equipment, like General Electric. So from 15 years ago, I remember we did a book on ultrasound, 2009. And 15 years ago, GE was putting a program where it tracks the follicles for you. So even Dr. Magid and I could be sitting in our office drinking tea in Egypt or otherwise, and then the ultrasound tracks the follicles day after day for you, gives it a color. So the red follicle is the 8 millimeter today, and it shows if it becomes 10 and 12 and so forth. And you don't have to measure, and we can't remember which one was which one. But these are the two big areas that I want to discuss, the embryology lab plus the clinical part. You will see that all the publications that came are basically in the last literally 36 months. If anything, the earliest publication I have is like 2020, and the most recent is this year. The first thing, it can personalize for you how much FSH you need or how much first dose. And it takes away all the debates, like Europeans like to start on a lower dose, Americans like to start on a higher dose. It takes away all that completely because it computerizes it in a way. So choosing the how much medicine, you just enter the data, the patient's age and weight, and then her AMH and maybe antral follicle count, and it calculates that for you as well. There has been different studies, basically non-inferiority studies, showing that the AI is not less than the clinically skilled physician in terms of ovarian stimulation, showing basically they are the same. Not that it is a million times better, but they are the same. But it takes away from us many things. For example, this morning, like all of us, I mean, I've been, at work trying to say, oh, with up the dose, down the dose, all that stuff. It can help you do that at the same level, which is a big deal, frankly, not because we are so full, but it also takes away some of the errors for days. It can predict also the number of days of stimulation. It can predict the day of optimal trigger. There are very, very few studies, despite the millions of studies in IVF on different things, on different medications, but very few studies to tell you what day should you trigger. Should you trigger at 18 or 17 or 16? Should you trigger at 3 follicles that are larger than 17 or 2 that are 18 to 20? All this, it doesn't randomize it or do anything like that, but it picks for you the optimal day of trigger, taking into account the change in the size of follicles as well as the estrogen level during stimulation. It also
Professor Boutros, I'm so sorry. So we haven't shared screen, by the way.
Probably I don't want.
Yes. I'm very interested in seeing you because I'm enjoying very much looking at your nice face and nice. But we haven't seen the slides. If it's difficult, forget about it. We are enjoying with your talk.
Slightly difficult because I have the
no. It's great. It's great. We are happy with that.
On my other laptop, and that is why you see me sometimes looking to the side, not trying to avoid the.
Okay, no problem. We are enjoying anyway. Okay, yeah. Carry on, please.
Thank you so much. I appreciate that. So I mentioned so far that the GE they started with their software that tracks the follicles, gives each follicle a color, red, green, blue, and then you don't have to go and ask the ultrasonographer, do you think this was a cyst from the beginning, or do you think this was an egg or a follicle that didn't change in size? It also remembers for you the uterine lining. Was it homogeneous thin, or was it trilaminar, and when did it become trilaminar, and how long did it stay for? Those two things are very, very important. So one big study from Mexico actually came analyzing that the endometrial analysis is a good marker for later on endometrial receptivity. So those are the two things that it is doing: ultrasound tracking follicles, endometrial measurements. It keeps key indicators for the IVF lab, key indicators being the fertilization rate, the cleavage rate, the blastocyst formation, and so forth. So for all of that, it automatically analyzes it for you and gives you a heads up when things go down. Like you have a couple of weeks in which things are not going well, then it immediately takes care of that and brings it to you. It also asks a very important question: do we need to have all those number of eggs? Do we need to have those number of embryos? So it predicts from the beginning the blastocyst formation rate from the oocyte appearance at the very beginning. And this has been a big challenge. So, for example, I would like to mention 2 or 3 studies, and this is where, frankly, the screen would have been helpful. The Reproductive Biomedicine Online this year had 4 or 5 studies from Europe mainly that has been showing that you can pick the rate of blastocysts and which eggs will make blastocysts depending on the information for an ideal egg on day 0 or the day of egg pickup, say this morning. It can tell you in 5 or 6 days which will be the best blastocyst or the poorest blastocyst. So that prediction is important as well. So that if today you have 20 eggs, you don't think that we'll have 20 blastocysts, then you find that we have only 3 or 4. The patients don't get disappointed and you do not get disappointed as well. Come to the male factor. If you put the screen for the ICSI on the thing, it can predict the best sperm depending on the pattern of motility of sperm. Whereas normally we do like an analysis for sperm for motility on a separate day and then come and do it on the day. It's totally irrelevant. But on the day of the ICSI, it can pick the best motility pattern, again, based on information that it has gained on the motility of those sperms. And then finally, the embryo analysis at the final day, it is a good supplement to the morphology. So we all know that morphology does correlate with the chromosomes, with the PGT, and practices differ exactly as Dr. Minawi was referring to in the robotic, the same for IVF. So when you come, for example, today in 2024 in our practice in, say, in Houston, Texas, where we are here now, we do genetic on 100% of patients. Does this mean that all the world everywhere should do genetics? No, but everybody should know his pluses and minuses and his strong points and weak points. For example, if you feel that the lab for some reason do not progress well from day 3 to day 5, and your embryos were good on day 2 to day 3, then you should consider that. I mean, just be honest with himself. We now moved completely to freeze all, and everybody has genetic. What's the percentage of patients? 100% of patients. The others would be an exception for that. Vitrolife and many companies, and I don't work with any of them, but all those companies have also put ideals for an appearance of blastocyst depending on the morphology. So again, if you look at some of the papers this year from Reproductive Biomedicine Online, where most of these papers have come, I would like to highlight a couple of papers that correlates what they call deep learning versus morphology and manual morphology. And they find that deep learning is as good. Again, there is nothing so far yet that has shown that it beats what we do, if you do it meticulously and so on. But it is as good as, and you can pick the best embryo for the transfer. We transfer, for example, single embryo transfer in 100% of patients. So there is no exception. There is no this. I mean, exception may be less than 1%. And again, no freezing less than 1%. Fresh transfers. All endometriosis patients, for example, have frozen embryo transfers because we find that the freezing allows you to improve on the lining in the when you do a separate cycle. What else? The time lapse and again, we're not promoting time lapse or anything like that. But when you correlate them, they do correlate. They do correlate very, very well. The most recent, again, publication was this year, literally a few weeks ago, and showing that you can predict diploidy status, whether they're aneuploid or euploid, from the artificial intelligence during the information on the embryos as well. So this is as far as embryology. So to relate my talk to the previous talk, I'm afraid that robotics are used very well in the IVF lab, to the point that there's 2 companies now that are working on making the entire lab robotically assisted. What do I mean? That the robot does prepare the dishes, does do the full ICSI from the beginning till the end, does monitor them, and does pick the ones for the transfer. So you would replace 20 embryologists with 1 embryologist. I don't know if that's a good thing or a bad thing, Dr. Mack. Yeah. But at the end, I don't think in a brief conclusion, that the robotics will replace humans, but they will be an integral part of the program in the future. And thank you so much.
Thank you very much, Professor. Thank you very, very much. Thank you for
Like-
sharing all the wisdom and experience. Thank
my
you very
honor.
much. We have a few questions. Lastly, for all the speakers, it was mainly after Professor Minawi's lecture about the medico-legal problems when they happen after surgeries with assistance of artificial intelligence. And the questions were curious about whom to blame and what happens when things go wrong.
Well, there are ethical committees currently working on things like this, but I mean, in the end, I think any blame for anything that goes wrong in any surgery falls squarely on the shoulders of the surgeon, because in the end, it is the surgeon, as I explained, we do not have autonomous robots. We do not have autonomous equipment. You know, the only autonomous piece of equipment that exists, you'd be surprised, it's the pacemaker. That's the only autonomous device that exists. Everything else is grade 1, 2, 3, 4, but nothing grade 5 except for the pacemaker. So if we're using augmented technology, for example, during surgery, all we're doing is projecting images to help the surgeon. So if there is a mistake with the preparation of the projection, if there's a mistake in properly preparing the overlay of the MRI imagery onto the patient, then I guess it would be, in the end, not related to the artificial intelligence or the augmented reality. It's related to the surgeon and the surgical team. So no, it falls squarely on the surgeon's shoulders.
Magid,
Yes.
if you allow me, it's a very good chance to have Professor Boutros with us, and it's a very good chance to use him strongly in the field of infertility. So to be there, he's a bonus for us. So if you allow me to ask him just question regarding to the shift, the paradigm shift or the new shift from just fresh courses of cycle to the freeze one. So you said that you shifted now to become all of them, or maybe 99% cases for freezing, followed by genetic screening. Does it affect the implantation and the success rate, or does not? Because do you know, as you know, in Egypt, one of our colleague, and I think you know him, he is the only one practiced that way during the last 10 or 20 years. Meanwhile, we have just conflict of the idea, and every time everyone try to attack him. But we see that just genetic screening, it's very expensive for us. But do you think that it's worth to pay all of that money to freeze all? I agree with you completely, because I shifted my training and my practice actually to freeze all now, every case. And the things that preparing the endometrium in another cycle is great. But the point is, doing genetic screening for everyone, do you think this might affect the success rate of ICSI?
That's a brilliant question, and again, thank you for the pleasure and honor of being on your panel today, and for the opportunity. All the prospective randomized trials so far did not show an increase in pregnancy rate. Some earlier studies were highly suggestive based on, say, pilot study showing that, for example, in year 23, they had 60%, in year 24, they had 70% because of the change. But when they randomized it, including the people that are the group that are the real pioneers of the PGT, it did not show a difference. However, I'll tell you, it's more details. Number one detail is that the genetics, say you have a polycystic ovary patient and she has 15 eggs today, and then they make 8 embryos or 6 blastocysts, 6 to 8. which one are you going to choose? They all look the same. They're all BB and a couple of ABs and a couple of CCs. So which one you pick? You pick one. Many times this one is the aneuploid one, and hence the patient doesn't get pregnant. And then you do another one, and hopefully we're lucky to have picked the normal ones, and she gets pregnant. Many patients, after trying 2 or 3 of those failed implantations, they succeed. But many of them get frustrated and give up because they can't keep doing this, despite that they still have embryos in storage. So it has definitely increased the speed to the first successful embryo transfer. There is no question about that. The way the results are compared now, they take a whole cycle and track it through. So at the end, it will not make a difference. If you do 4 transfers and on number 4, you pick the euploid one and tried 3 before that were aneuploid, I mean, she still got pregnant from this batch of eggs that she has, similar to herself or similar to her sister who had the same and had genetics and found that you have 1 or 2 that are normal and the other 6 are abnormal. So you have increased the speed, that is for sure. Number 2 is that when it fails, we want to know why it failed so that we see if we can improve or not. I mean, we generally say that 60% is the embryos, 40% is the uterus, or 70-30, something like that. So we want to focus. But when we don't know, we're not sure which one of them. For example, all the studies on hysteroscopy during IVF and so on show that the hysteroscopy does not improve the first attempt and does not improve even those who failed before. However, we employ it because definitely you find things. A very dear colleague and friend with me here, Mustafa Abu Zaid, we did one time a publication close to my heart, and maybe I've given it more times than any other. We've taken 7 patients that failed IVF at very good centers. Very, very good centers in the US, and they failed. And they came to us. And we did for them HSG and then 2D ultrasound and 3D ultrasound and then 2D and 3D saline infusion sonohistogram, then office hysteroscopy and operative hysteroscopy. And this is actually in one of our books on ultrasound. We put a cartoon of the same 8 figures for each individual patient. There was no correlation between the finding that the patient had on the HSG and between the final finding on hysteroscopy. Like the HSG perfectly normal, and you do the hysteroscopy, you find that she has a medium-sized polyp and a small submucosal fibroid that was not there, or that you have a slight septum and so on. And then we showed that we picked 7 patients that we have corrected the uterine factor and they conceived. Not to say that we did better than those centers. All those centers were very good centers and they had good embryos, but the more you fuss about it, the more you find things. Despite that, all the meta-analysis for the hysteroscopy shows one conclusion. Hysteroscopy did not improve women with recurrent implantation failure. But again, you take 20,000 patients from 10 centers, etc. Whereas when you really focus on one thing. So this is the second thing that we think. The third thing is that it helps you in selection of the PCO, like I said, because they have a big number. Which one are you going to use when you have 15, 16 eggs? And in endometriosis now, it is an accepted scientific fact that really the stimulation does not bring the best endometrium, whereas in your frozen embryo transfer cycle, you do things and so on. Put on top of that the real part, the real life. So I trained my original training in England, and my first year was a guy. He passed away sadly last year in London. He was a phenomenal guy. He trained all his career in Queen Charlotte, in the Central Institute and so on, where you have facilities for everything. But at the end, we covered 2 hospitals. One of them was a hospital on an island in England that we had basically, the facilities were me and him alive and a couple of forceps and a C-section guy that we call him, and he might come in an hour. That was and honestly, I mean, I enjoyed with him that we worked at both. I mean, we worked at the University of London, and then we worked at this island in which there was the porter, the guys that bring the patients quickly, and anesthesiologists. We call him at home if he comes. So you have to modify the practice to think. if you feel very comfortable, for example, with the genetics company, that's a big asset. The technology between them varies and varies tremendously, and then they use pieces of primers. The overlap between the primer is important, so some of them miss things that others don't miss. We also try to use companies that have very low mosaicism. For example, our mosaicism rate is very low. The patients that they come with that is a handful of patients. So we do not have all these questions. Although mosaicism has become an easier answer, that generally people are more open-minded about. But in general, it depends really the facility, and then also the biopsy itself. We do assisted hatching on day 3 on all of them, so that we facilitate extrusion of some of the trophoblast, so that the PGT is done easier and there is no damage. So all these details, I have changed completely about 3 or 4 years. Before that, it was very selective, and before that, it was really against. Against actually, Ob Gyn, a dear friend, we published a book together called Controversies in Assisted Reproduction. And he's against 100%. At the time, I was making the shift to in between. So we got two writers. One said that is the best thing, and one said it's the worst thing, in the same book, with different experience. But prospective randomized trials are good, but they are not the answer to everything. They lump a big group of patients into one session, into a big group, and then suddenly you lose the detail. I think you can individualize. And you can, I think for endometriosis, there is no question. For polycystic ovaries, there is no question. For others, I frankly am not very, very accurate in the day of the retrieval, because it's affected by many socioeconomic things. I mean, who's working on this Sunday? Who's available? Fortunately, now we took the line that we're available 24/7. But sooner or later, you want to modify that. I mean, she's ready for day for Saturday or Sunday, but it's the weekend, so you push her to Monday. Well, it doesn't have an impact on the embryology so much, because there is a big number of embryos, and the technology with ICSI freezing and so on overcame that. But it didn't really overcome anything in the uterus. So that uterus is not as receptive as one would like it to be.
Thank you very much. It's great. Great. Thank you very much. And the book is available now, this controversy in the market, or not?
The book is available. It was
available. Okay, that's great.
Yeah. And then Dr. Magid written in all of them a lot.
That's great. Magid?
Thank you very much, dear professors, for excellent and inspiring lectures. I think we all learned a lot today about artificial intelligence, and we all think very positively about artificial intelligence, and thank you very much all. It's been a great webinar. Professor Yasser Abu Talib is going to give us the closure. Thank you very much, Prof.
Okay. So I don't know what, to be honest, no comment actually, but it's a great pleasure actually to have 3 eminent, I don't know, persons, pioneers, and I don't know how to describe all of them. Professor Dr. Botros, Professor Dr. Ahmed Manawi, Professor Dr. Magid. So to be honest, I'm impressed actually, and I enjoyed thoroughly by this. It's no presentation. It's to be honest, it's a scientific, great, successful meeting. Just at least for me, and I hope this for everyone as well. I gained lots of new information, and I met friends. So thank you very much for this wonderful collaboration and wonderful effort from everyone. And looking forward, first, whoever is outside Egypt, to see you soon. Professor Botros and Professor Magid, hope to see you soon. Just to invite you for battu, wizzu, ducks, and so on, and so on. I think Dr. Ahmed Al-Manawi, he's a very slim, nice guy. He used to keep his nice body, so he's not interested in but with, I know. But anyway, I will try to change his behavior to like what we are going to eat. So thank you very much. And I would like just before closing to announce again our Congress 11th and 12th of December, where Professor Abu Ghar, Professor Hassan Salam, Professor Gamal Abu Surur will be the pioneers and the head of this meeting, representing the Royal College, as well the team of the Royal College. Next slide, please. Rani, Hassan Shahata, Kate Lancaster, Asma, and Sharif will be there. Next slide, please. And as well, what's new, we invited all the MENA region. We are trying by all means, since we met during the last RCOG exam in Dubai, maybe 6 months ago, to have a sort of collaboration, to put hands, to put just one unit in the MENA region, to have some sort of activity. And from here, we invite all for collaboration to produce lots of webinars to have good contact. That's why we have regular contact with all chairs from the MENA region, Jordan, Saudi Arabia, Abu Dhabi, Qatar, and Kuwait as well. We will have during our Congress lots of scientific activity. We used to have many courses: total laparoscopic hysterectomy and urogynecology course, including pelvic floor repair, third-degree tear, oncology and colposcopy, hands-on assisted reproduction. And I think Professor Bulgar, lots of persons will share this activity. And I would like just to announce as well the second part MRCOG course, which has been started maybe 3 or 4 months ago. The coming course will be 4th of October. And I urge everyone interested in going through the membership of the Royal College to participate in this course, because he will gain lots of information and knows how to answer questions. And lastly, don't forget to just to go through our communication. So this is my phone number, this is my our email, and the most important thing, our webinar. You will enjoy very much going through our webinar, which is in direct contact with a YouTube channel, where we're going to put this wonderful webinar on the YouTube channel, besides other webinars as well. And as well, I would like just to announce 2 future webinars after 1 month or 2 months. The coming one will be endoscopy, including hysteroscopy and laparoscopy. And the following one will be placenta accreta management from England to Egypt and India as well. Thank you very much, and enjoying very much contact you. If you want to have any comment from anyone, we will be more than happy. Any comment?
Thank you so much. We are very honored.
Okay, thank you.
Thank you very
all.
much.
Okay, thank you. See you then, and thank you very much for attending this meeting. Have a nice night and a nice day for Professor Botros, because it's morning, I know, and hope to see you soon. Okay, see you then. Bye.
Thank you so much. Have a good night.
Yeah,
Bye.
good night.
Bye-bye.
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 Bye-bye.